Okay, this is to talk about Chapter 3 in the Stanhope and Lancaster Public Health Nursing, Population-Centered Healthcare in the Community. I wanted to start with talking about Alma Ata because this lays the groundwork for the interest in primary care and primary health care later on in the chapter. It was family practice was not considered a specialty until the 1960s, and so people weren't going into it because the doctors could make more money in the specialties, and some of that remains today, but we're working on getting physicians into the general family practice. The Declaration of Alma Ata was a model of primary care. It came out of Russia and was declared, and several nations signed on to it, which said that health is a human right and that health should be the goal of all governments. And so the health system should be based on a primary care system. What was interesting about this is that traditional healers would be a part of this, and also community health workers would be a part of this Alma Ata. The United States did not sign on to that. The next year, or this was when Jimmy Carter was president, which is a little bit surprising, but may have had to do with the Russian influence. So we know that nurses play a role in healthcare, and nurses need to be, especially public health nurses, need to be aware of the forces that have an effect on the healthcare delivery system and the use of healthcare. Demographics play a big role. We know that in Pennsylvania, I think we're the second largest state of elders, people over 65, and that number continues to increase. We know that people over 65 use the healthcare system more than middle-aged people, more than young adults. Young children use it as well, and we do have an increasing population in Pennsylvania. We have, and in the United States, we have births rising, and all of these put forces on healthcare. The social and economic trends that affect healthcare is the amount of money that we spend on fixes for health problems. So our diet money, our headache money, our creams and lotions that you can buy that solve arthritis, that cure you of arthritis, that cure you of erectile dysfunction and things like that. We know that income distribution, so if people are working and they have insurance, that affects who uses it, because if you have insurance, you're more likely to use that insurance than if you don't have insurance. And so then there's more people having appointments. If any of you have ever had to try to get a dermatologist appointment, there's sometimes a long wait because so many people are using the system. Other factors that affect it are workforce trends. So we have aging nurses. We have to replenish our supply of young nurses coming in. We have nursing shortages. We have a shortage of nursing faculty. We have a shortage of physicians in family practice. We understand how long it takes to create a doctor. And so we've worked with nurse practitioners, which are much faster to get into the workforce than a family physician. And then we have distribution issues where we don't have a strong workforce in rural areas. We have shortages, of OBGYN doctors and pediatricians and other services in rural areas. Technological trends also affect healthcare delivery. A lot of the new advances that are coming out create tremendous burden on the system because they're expensive, but we have to make sure that the evidence shows that they are having improved outcomes and not just the same outcome, because if it's the same outcome, we should use the cheaper version. Electronic medical records are helping with acknowledgement of these trends, being able to track people using healthcare and what their diagnosis is. So our current healthcare system is affected by these three things: cost, access, and quality. And so again, when somebody doesn't have insurance, they're not going to use the system. We look at the numbers. Employment is up, but are the number of insured up? People still need the Affordable Care Act insurance. People still need that the pre-existing conditions are not costing them more. Insurance can be very expensive. Access to care, we have this two-class system, this private system which is viewed as superior to the public system being Medicaid, being viewed as substandard care, but the private system being my insurance pays for my private doctor and my services, and my system is better and cleaner and stronger. There's a lack of preventative care for people who are uninsured. When you have to pay $150 for a vaccine, excuse me, you're not going to get it when you have to pay for other preventative services, getting your blood pressure checked, getting your diabetes things monitored, your diabetic supplies, for preventing disability. It's going to be a problem. The lack of providers as well. Again, in rural areas, when you don't have providers available, or you have a provider 1 day a week, access is difficult. Quality, safety is a big concern. We are putting in place more safety so that people are not falling, so that people are safe in their homes. And then accreditation plays on the term of quality, because when we have certified workers, when we have masters of public health nurses working in jobs where decisions are being made, we have better quality of care. The primary care system, so again, we're talking primary care. This is the gateway, this is the entryway into the healthcare system. You don't get into a hospital usually unless you have a primary care doctor, although we know that people can go to the ER and get in and then get out into the primary healthcare system. But typically, you have a family doctor, you have the primary care doctor, and that puts you into the healthcare system. With managed care that came about in I think around the 80s, we have the physician who's the gatekeeper. The physician is making the decisions. We're going to try this treatment, we're going to try this treatment, and then you will go to a specialist if you still need it. But I'm going to be the one who tells you can go to the specialist. Whereas the open plans of insurance, the old Blue Cross and Blue Shield plans, people just were covered by doctor's care and they could go whenever they wanted. We have the Medicare and Medicaid paying for primary care services, and we do see that in the case of Medicaid, a very poor payment to providers, and so some providers will not accept Medicaid clients. Now, primary health care is mentioned later in the chapter, but I want to mention it here because it is a system that we can help to promote, that we can help to watch out for. Primary health care, not primary care, but primary health care is an integration of public and private health care so that all of the comprehensive services, the x-ray, the ultrasounds, the diet planning, the nutrition, the primary care doctor are all together. Services from prevention of vaccines, prenatal care, to end-of-life care, palliative care, helping a person through their lifetime. And primary health care relies on community participation in making decisions about what services are wanted, how coverage will happen, where services will be. Astonishing, right? This is really a different system than what we're used to. The World Health Organization supports primary health care, so I have a link. When you have these slides, go to that link and read more about primary health care. And again, primary health care comes out of that Alma Ata Declaration of Health for All, Healthcare for All. The public health system in the United States can be at the city, local level, the county level, or the federal level. It's provided with government money when it's called the public health system. It provides public laws to protect people, mandatory vaccination for schools, mandatory trash collection in areas, no dumping of oil down the sewers, things like that. And then gives mandates for the provision of direct care, which public health nurses do. So we have the HHS, the Health and Human Health and Human Services. At the federal level, this man is the secretary in charge. That is a cabinet position. He reports directly to the president. He's appointed by the president. There's very many levels under that secretary. On page 51, take a look at that flow chart, but you can see the U.S. Public Health Service is under there, the CDC, the Office of Minority Health, the NIH, and many, many more services are there. The state system in Pennsylvania and New Jersey, again, when you have these slides downloaded, you can click on these links. You can get some of your data from there. And then there's a link for a description of a community health nurse in Pennsylvania. And then we know, Heather, you would have a link to the New Jersey job description. And the last one is the vector-borne illness in New Jersey. And that is I think it was a week-by-week report of Zika cases, West Nile virus, locations, county, really, really just interesting to look at. In Pennsylvania, we had a problem. We had a governor who had to cut the public health clinics, or chose to decrease the number of public health clinics from 60 to 34. Nurses lost their jobs. You can see a link there to read more about it. Nurses are to protect health and to prevent disease. So who's doing that now, and how are the communities working when the Affordable Care Act was under attack by the administration and the services were cut? The local system then is your local little city area. Philadelphia is a local system. They focus on emergency preparedness, vaccination clinics, information, health education, epidemiology, safe sanitation, safe practices, laws for carrying out the laws and restrictions on sanitation, and then again providing direct services. So we have the health department clinics in Philadelphia. And Heather's job. The American Nurses Association has made statements that healthcare is a basic human right, that health policies must be patient-centered and equitable for all. Equitable meaning people get what they need, not equal, where everybody gets the same thing. Equality is not what people need. It needs to be equitable. They need to get what they need. The ANA says that we should promote prevention. All nurses should promote prevention and health promotion and disease prevention, and avoid the overuse of this expensive technology. Simple screenings, health education, exercise, not needing expensive machines for these things. And then the ANA supports a single payer system or the Affordable Care Act. And that's all I have to say. I hope that this helps you to understand Chapter 3 and some of the items that are important in understanding our healthcare system, because public health nurses need to know how payments are being made and where money is coming from, or where money can come from. Thank you.